A very good morning, everyone. My study is on retinal vascularity index in affected and fellow eyes of BRVO patients using a purpose-built semi-automated software. Way back in 1876, Gauss first noticed the narrowing of retinal arterioles in a patient with hypertension. Subsequently, Keith Messner and Wong Mitchell came up with the classification of hypertensive retinopathy based on fundus changes. Arteriovenous ratio or AVR is an important clinical marker when we talk of retinal vessels. The ratio varies according to different reports in literature, but this variation is due to taking of non-comparable vessels while measuring AVR. Also, we know that AVR is not uniform and it varies in different quadrants of the eye. And one such clinical implication of regional AV changes is BRVO. However, in the traditional method or the slit lamp biomicroscopy to measure AVR has drawbacks. Firstly, it's subjective. Secondly, when we measure the AV ratio taking arteries and veins around the disc, and that is taken as a global index that overlooks the regional variability that may be present. To overcome this subjectivity, we came up with a purposely built semi-automated software of our own that we have applied for patent to measure the AVR. And in this study, our aim was to compare the AV ratio. We calculated retinal vascularity index by measuring the AVR between the BRVO eyes to healthy controls and also in the fellow eyes of BRVO patient to healthy controls. For this, we used disc and macula centered fundus images as per the ETDRS standard fields 1 and 2. And the images were uploaded into the software. The software automatically divided the image into 8 regions in 4 quadrants and concentric circles 0.51, 1.5 and 3 disc diameters away from the disc. And the AV ratio was calculated at specific loci in all of these regions to give the retinal vascularity index. Coming to the results, we studied 420 eyes of 280 patients, 140 BRVO eyes, 140 fellow eyes, and 140 healthy controls. The mean age was 56 years. Coming to the AV ratio, if we talk of a whole, the AV ratio or RVI was significantly reduced in all the quadrants in patients with BRVO and also in their fellow eyes as compared to the healthy controls. Now, what is more important and interesting is if we take into account the quadrant-wise analysis, we see that in the supratemporal and inferotemporal quadrants, we have significantly reduced AV ratios as compared to the nasal quadrants, and this is fair to get the results as the temporal quadrants are more affected in vein occlusions. So to summarize, affected and fellow eyes of BRVO patients show reduction in AV ratio or RVI as compared to healthy controls. AV ratio in mid-periphery and sectoral AVR is also important rather than measuring the global index. An innovative purpose-built semi-automated software has an important role in bringing the objectivity to this analysis, and this study can act as a baseline on which we can develop the deep learning algorithms and finally moving into AI algorithms to predict the systemic health and the hypertensive control of the patient vis-a-vis his fundus findings.
That's a great thing, but one thing, as you are measuring the vasculatures and AV crossing as a hypertensive patient, you are not taken consideration the lipid profile of a normal healthy.
In this, we took the BRVO, only the hypertensive control, and we have not looked into the other metabolic factors. We were just analyzing the patients of BRVO and normal healthy controls without any evidence of metabolic syndrome. Further moved into the systemic control or so, that would be next step. This was just a preliminary step to find out whether we find any differences and to validate this software.
How do you acquire the AV ratio?
As I told, this software is semi-automated. Once we upload the image, then the operator has to select the disc and the macula as on the images. The machine automatically divides into different regions. Then the observer clicks on these. This is the vein. This is the artery in specific loci, and the AV ratio is automatically calculated and told.
But won't the corneal topography, the retinal surface topography change in an active disease and variability of the disease, and then how won't it miss? I mean, sectioning, how will it do?
That's why we have multiple loci and different positions. Like if a topography is altered in a particular loci or a sector, we omit that for the analysis, and we can take, like, we have 8 regions and different concentric circles. We only take those vessels that are definitely delineable, and the points can be marked. Like if we talk of BRVO, if we have an overlying hemorrhage and that is obscuring the underlying vessel, then that will not be taken into analysis. That loci can be omitted.
But that for that particular patient, then that area is basically missed also, no?
That's why we have like in supratemporal quadrant, we have 5 circles. If we miss in 1 or 2, then we have next 2-3 regions to so we are not missing out on the quadrant, but we are taking different points, and then that's why we have the whole of the like if we summarize all the data, so that minor differences are omitted. Rather than taking the false values, it's better to leave that, because we have multiple points to take. Even in a single circle, we can take up to 3 points.
And does the algorithm also take into account the change in the vessel caliber normally also in so my question is, like, how can you study a central 30 degree to a peripheral 60 degree?
So the comparisons of the p values or are quadrant to quadrant. Like if we divide the supratemporal quadrant into 4 parts, then it will compare ST4 to ST4,
Okay,
ST3 to ST3.